neonatology. In fact, for talking about the detail of the subject, you should know certain definitions. Of course, you know the period of pregnancy about 280 days. Of course, calculated is clear for you. Important to classify newborn for at least 3 groups regarding the maturity of the newborn. We should know what we mean by preterm or premature and what we mean by term or post-term. This classification is so important because each of these groups has its peculiarities, because certain disease or condition may be related to the preterm of post-term newborn. What do we mean by preterm? Any newborn that delivered before week gestation. Term, 3 weeks up to 42 weeks gestation. While post-term, of course, after 42 weeks of gestations. Sometimes we say premature or preterm, but never mention of gestation. So when we say this is a preterm, or we mean every newborn that delivered before 37 weeks. Keep this classification in your mind. Newborn. Newborn in your natal period, of course, define newborn up to 1 month after, precisely 4 weeks after. We call this period neonatal period. Neonatal. Of course, this neonatal period may be extended just for premature newborn. For premature and even extremely premature may be defined in a long period than 4 weeks. Keep this in mind, but in general, born on neonatal period, of course, we talk about the newborn and month of birth. Clear? So this classification important because, as we say, certain disease related preterm, but not for term or post-term. Keep in mind. Of course, before labor, we have a fetal or growth, and later on, after birth, we have a neonatal growth. In utero, fetal growth rate about 5 grams per day at the first trimester, increased up to 10 grams per day in the next or the second trimester, and increased so on, and reach the maximum fetal growth at 32 to 34 weeks of gestation. Later on, the growth may be slower than this percentage. Keep this in mind. After birth, also we have neonatal growth. Immediately after birth, we have a loss of a certain percentage of weight due to loss of extracellular water and less caloric intake. So the weight start to be reduced in term up to 5% of their birth weight, while preterm may lose more, up to 15% of their birth weight. So you should inform the parents about this fact. Loss more than this person that we mentioned considered abnormal. After that, of course, the terms start to regain by the end of the first week of life, and the growth about 20 to 30 grams per day. So normally the newborn starting weight after birth, as we mentioned the course, after that week or from the 10th day of birth, newborn start to gain of the newborn. So we start to be ready as such a new human being, and all the time we are ready to introduce a help for this new human being. So the goals of our management of this newborn as follows. First, to assess the immediate need of this newborn. Of course, the most important thing is oxygen, and if he needs to initiate ventilation. So assessment of oxygen requirement, ventilation, that means respiratory movement, or to deal with certain serious anomalies. So all the time we are ready to deal with such critical situation for this new human being. So all the time we are ready to resuscitate and prepare all the equipment that may be needed for such resuscitation. The room of resuscitation of the newborn should be nearby of the delivery room and should have adequate lighting and space for personnel and equipment for freedom of the movement of the team of the resuscitation. Of course, receiving of this newborn, you have a certain detail regarding the delivery. So, the pediatrician must have specific information concerning the mother and the fetus to be ready to deal with any problem that may face you in resuscitation. So always keep yourself ready for first newborn problems. Obstetrical that should be included in your case sheet should include important information of situation and medical staff should know about the highly risk group of the mother that in delivery room. So maternal age, medical previous obstetric history, length of gestation, blood group incompatible, maternal infections, maternal drug use, ultrasound evaluation of fetal growth, and amniotic fluid volume or congenital anomalies. Sign of chorioamnitis, including rupture of the membrane, fever, and leukocytosis if investigation available. So all of this obstetric history should be available in the case sheet that you deal with. Within labor, you should assess fetal heart, duration of the fetal membrane rupture, evaluation of amniotic fluid, color and quantity, and progress of labor beside, if available, fetal blood pH. So, in this paragraph, you should take a general idea about the women or the pregnant women and the state of her fetus. A team that should be resuscitate this newborn should know the high-risk deliveries and can deal with each of these risks separately. Of course, all the team, including the leader and others, should know these high-risk group like ABO incompatibility, multiple gestation, maternal bleeding, severe eclampsia, retardation, fetal breech presentation, or a previous cesarean section. What is a fetal distress? So, if you face a case of a highly risky delivery, the team should consist from a team leader with 3 helpers or 3 assistants. Leader, of course, direct resuscitation and direct and institute air. So the leader of the team, of course, responsible of the newborn. The other assistant assess the heart rate and may need to initiate a cardiac compression if needed. The other assistant start to dry or suction or ventilate or prepare drugs for injection. And the other assistant can deal with gaining intravenous access for drug administration. So this team should be act in an organized manner. Of course, this team should be well trained to deal with different risk deliveries, of course, to reach the optimum result and to prevent presence of the birth asphyxia. So the team leader, of course, deal with the most important part of resuscitation, and that airway management. And the other, of course, deal with the others. So each of these assistants know what he do. Each of these members know what his job. Equipment should be available for resuscitation. Equipment should be available, of course, and it should be and we have different catheter for suctioning available, Tracheal tubes, laryngoscope, suction catheter. Ventilation and oxygenation equipment should be available, like oxygen source, mask of different with oxygen reservoir. Intravenous catheter available in different size, of course, with normal if we have a hypotension. Drugs that may be needed, like a plasma volume expander, sodium bicarb, or naloxone. Of course, this drug can be needed according to the state of our patients. This equipment should be available in the room of resuscitation. Of course, it is examples. It's of course ampupac that used for ventilation. This is a sucker to suctioning a different secretion, and this is a tracheo. In the tracheal tube, of course, we have a different size. This is the airway that can be used in certain conditions. Of course, this is a laryngoscope. All of these certain equipment that can be used for resuscitation. Any question, please, regarding this introduction? أي سؤال يا شباب؟
واضحة دكتور.
واضح. خير إن شاء الله. In fact, when we deal with the newborn resuscitation, should we have a simple language to be shared with the medical staff between the doctor and the nurse that should be expert in dealing with the neonatal or newborn resuscitation. We have a simple language to be deal with us by assessment of this newborn. So we have a practical way to be that tell us about the well-being of the new and tell us this newborn to be immediate intervention and tell us this newborn in a critical zone. This newborn is well. So we have what we call Apgar score. So we have a certain scoring number should in the case sheet of our newborn to know the oxygenation and ventilation of that newborn. So Apgar score is a practical way to know which newborn that may the goal of the newborn resuscitation to prevent what we call the birth asphyxia or hypoxia. Your job to prevent this condition that may result in bad sequelae later on if you didn't deal with it in a proper way. This is the 5 variants of the Apgar score. We have a heart rate, respiratory rate, muscle tone, response to the catheter in the nostril, beside the skin color. Each of these variants numbered with different scores. Each of these variants may be take 1, 2, or even 0. For example, heart rate, if not detected, should marked with 0. If the heart rate less per minute, should be marked with 1. And if we have optimum heart rate more than 100 beats per minute, of course, the mark up to 2. And so on the other the Apgar score. This table summarized and should be kept in mind, and it's a simple practical way to assess the newborn state by observing these sign of these 5 variants: heart rate, muscle tone, response to the catheter in the nostril, skin color. For example, skin color, if the newborn totally bluish or pale of cortex 0, of all the body pink while the extremity is blue, take 1. If the newborn entirely pink, include foot, hand, mucous membrane, this of course marked 2, take 2 in our score. This is so important, practical way. Keep in mind and don't forget. And of course, all the time ask me if you have any problem. So, to be again with the Apgar score, it's performed at 1 and 5 minutes after birth, and of course repeated at 10 and even 20 minutes after birth. So you can repeat it at least 4 according to the well-being of the newborn. As we said, all of these vital signs should be recorded. Apgar score of about 8 to 10 reflect a good oxygenation and ventilation and indicate no need for rigorous resuscitation. That's mean my patient. So if I don't examine the newborn and I ask the nurse to tell me the number of Apgar score, if she tell me this Apgar score with 9 or 8 or 10, of course this is a good news. This newborn not need for resuscitation. Everything goes well. That's optimal. But if I write Apgar score less than 7 or from 5 to 7, indicating for stimulation and maybe need oxygen. Apgar score less than 5 indicating for assisted ventilation and possible cardiac support. So the last group that need to be interfere immediately to prevent that what we say birth asphyxia. Birth asphyxia to me it's a disaster. Shameful thing for us to make this newborn asphyxiated while he delivered at hospital in the presence of us. You should hurry for help as such a newborn. Keep this group in mind, please. So Apgar score should be applied in this way. As we say, Apgar score should be done at first minute, 5 minutes, 10 minutes, 20 minutes. The most important part of Abgar score at 5 minutes reflect the adequacy of resuscitation and the degree of perinatal asphyxia and predict the next future sequelae. Normally, the newborn may give us low Abgar score at first minute of labor, but it should be increased at the 5 minutes. If this Abgar score never increases at the 5 minutes, that it means my patient may suffer more and more regarding asphyxia. And I expect next neurological sequelae after low Abgar score of 5 minutes. So assessment of the Abgar score at 5 minutes to me more important than assessment of Abgar score at birth. 5 minutes mean my newborn not respond well to my resuscitation, maybe due to a delay in introduction of resuscitation, or maybe due to other abnormality regarding my patient, for example, congenital abnormalities that may prevent a response of such newborn to resuscitation. So as we say, resuscitation should be done by a well-trained staff from the doctor and the nurse, and should be dealt in appropriate way. What are the routine procedures after newborn? So after receiving the newborn, you should deal with the following condition. A, maintenance of the body heat. The issue should be dried and provide with radiant heat to maintain body temperature. It's important to avoid hypothermia, which will increase the newborn oxygen consumptions. So the newborn should be cleaned with sterile material to prevent a more heat loss or energy loss. And immediately after birth, infant should place in a neutral or slightly extended position, and the airway established by clearing the mouth, nose, and pharynx of thick secretion or meconium if present. Keep in mind, deep and frequent oropharyngeal suction should be avoided because it may increase the vagal output, causing apnea and bradycardia. So we need the one that consider more expert to deal with such suctioning. So before starting airway initiation, you should clean the way. You should clean the way. So after cleaning the way, if ventilation is adequate, supplemental oxygen may be given to improve heart rate or skin color. So oxygen by mask, of course, may be needed. If oxygen supplement does not improve the heart rate or skin color, or if the ventilation is inadequate, mechanical ventilation should be initiated using mask or ambu bag. This, of course, give oxygen in a better way to aerate or stimulate the respiratory passage. So if stimulate the newborn and give oxygen by usual way and not improve, start to use ambu bag and tactile stimulation. You start push oxygen in. If spontaneous ventilation improve, that's okay. Mechanical ventilation should be stopped and supplemental oxygen resumed. Of course, this is the best work for us to improve our newborn and make him or her to be breathe spontaneously. Of course, if the newborn in this stage not improve spontaneously after complete delivery, we may enter what we define birth asphyxia. So if the response poor or if the airway obstructed, endotracheal tube should be inserted and mechanical ventilation continued. So in this paragraph, we graduated in our resuscitation according to the response of the newborn. So we start step by step. Our goal to make newborn take spontaneous, active breathing. So we start with dryness of the newborn, and we start to deal with the open airway. After that, we should assess the circulation. So, in most of the newborn, when you start with opening and initiate ventilation, the heart rate starts to improve spontaneously. Most of the newborn, if you initiate breathing and aeration beside oxygenation, the heart rate in most of the newborns start to improve spontaneously. We can assess and deal with the heart rate, of course, according to the counting beats of the heart. So, if the heart rate is less than 6 beats per minute or between 6 to 8 beats per minute and not improving, we start cardiac compression, of course, initiated over the lower third of the sternum. You should press on this area at a rate 60 compression per minute beside 90 compression per minute plus 30 breath. So the ratio, it should be 3:1. 3 compression at the lower third of the sternum, and then give 1 breath, 3:1. If the heart rate not improve, epinephrine is administered via the umbilical vein or even the endotracheal tube. Epinephrine, that means adrenaline, of course, can improve the heart rate when we start the compression and the heart rate not improve. Of course, we hope the newborn start to improve in this stage. If not improving, it means newborn may be in critical zone. So The newborn need you in this stage when we face a heart rate less than normal, especially undetected pitch or even bradycardia. Keep in mind, not delay the resuscitation, start the compression, start to ventilate, and if not response, you can add epinephrine. If the heart rate beats more than 80 or greater, but there is a poor perfusion or weak pulse, plasma volume expander may be needed. So it means my patient need to expand the circulation, and of course, a normal saline should be available at the resuscitation room, and my newborn may need 15 ml per kg. This given, of course, through the umbilical vein, not arteries, of course. As you know, we have a one vein that directed to the portal system and then to the right heart, and we have two umbilical arteries that comes from the internal iliac. Your catheter should be inserted to the vein, not to the arteries, because if you touch or insert inside the artery, we have a vasospasm that may affect the limb. So keep this information in your mind. The catheter should be inserted in the umbilical vein, not arteries, not arteries. So the heart rate should be observed closely, and don't leave the newborn unless the heart rate start to be improved and beat regularly. Drugs should be available in the resuscitation room, and we have examples of drugs that can be needed in most of newborn. We talk about epinephrine, we talk about the sodium chloride, normal saline, and we have sodium bicarbonate should be available. Besides, if we have a prolonged resuscitation and that metabolic acidosis may be exist, to deal with this problem, we can use a sodium bicarb, 2 milliequivalent per kg. If the mother receive narcotics, naloxone should be available in a dose of 0.1 milligram per kg, can be used. Keep in mind, naloxone not be worked for addicted mother. Dopamine, if we have a delayed improvement of the myocardial function, at that time, dopamine should be inserted by drip in a dose from 5 to 20 microgram per kg per minute. This drug should be monitored closely and, of course, under supervision of the well-trained staff, because this drug not given in a usual ward should be given as intensive care and should be followed by specialists. Of course, all of these equipment should be kept in your mind from dealing with the newborn. For me and for you, this introduction and to become the first lecture so important for the newborn, because if you fail in these steps regarding resuscitation, of course, you may leave the newborn with a permanent sequelae, especially neurodevelopmental abnormalities in the next years. So the staff, all the steps that should be needed for each newborn, because you are the leader of the resuscitation, and all the time teach your team about each risk factor of the deliveries and how to deal with each problem that may present for each newborn. أكو سؤال يا شباب؟